Today, we have the pleasure of hearing from Tadiwa Waungana. Tadiwa did his undergraduate degree at the University of Alberta. He graduated in 2021 with a degree in materials engineering. He then joined Sarah Mansky's lab here at the University of Calgary in 2021 to start his master's degree in biomedical engineering, where he studies the structural joint assessment in knee osteoarthritis using weight-bearing CT, which is what we'll be hearing about today. Aside his current research interests, aside from that, are related to sports-related knee injuries in the context of post-traumatic knee osteoarthritis and using weight-bearing CT to image these knee joints. His most proud scientific accomplishments include designing, fabrication, characterization, and testing of a ceramic superconductor pellets. Being able to make a magnet levitate made him feel like a magician. So aside from the scientific work he does, he's an avid sports fan, watches soccer, rugby, tennis, and he enjoys camping and painting and drawing. So I'll turn it over to Tadiwa, who will be giving a talk today titled Imaging Characteristics of a Weight-Bearing Cone Beam Computed Tomography System.
Okay, thank you for the introduction and the opportunity to share a little bit about my research with everyone here. And so just to give an overview of what this presentation will be about, I'll start by providing just some background, which will be hopefully useful in providing some context on how and why these sorts of scanners are around today and how they've been used, particularly in the context of studying knee osteoarthritis, which is sort of central to my master's project. And then I'll talk a little bit about both weight-bearing and cone beam CT before I go into some of the characterization work which I've done to date. And then finally on some specifics which where I'll go into what I'll be doing for my project going forward. So as most of us know, OA is one of the most prevalent musculoskeletal diseases in the world and continues to be one of the fastest growing MSK diseases to date. Something which may be of relevance to us here in Canada is that some of the most recent numbers indicate that 1 in 7 Canadians actually lives with some type of OA. It is a chronic condition that affects all structures of the affected joint, of which the hand, knee, and hip are most commonly affected. And when it comes to knee osteoarthritis, of all the joints that we saw earlier on, knee OA accounts for just about over 80% of the global osteoarthritis burden and can occur in both the patellofemoral and tibiofemoral compartments of the joint. Some of the hallmark features of OA include joint space narrowing, osteophytes, and sclerosis, all of which we can actually see here on the image. So we have an osteophyte, we have some medial joint space narrowing where the distance between the femur and the tibia is decreased. And then we have sclerosis where we see this brightening of at the bone margin here. Other features which we also see are degenerative changes in the cartilage in the meniscus. And so when it comes to knee OA assessment, there are a few ways that knee OA diagnosis can be established. And we see here that there are different criteria which may be used when a diagnosis is established, primarily based off patient symptoms and clinical signs. So for example, if you're using this EULAR criteria, you see that depending on the different combinations of symptoms and clinical signs which will be required for each criteria. And we can also see that knee OA may also be diagnosed based off radiographic findings. However, for radiographic findings, a clinical diagnosis will usually be based on whether or not there is sort of definite joint space narrowing. But in research settings, we do see that additional structural changes may also be used to grade the severity of disease. Now, one of the key requirements for knee OA imaging is that the joint has to be loaded or configured in a way that is representative of how the joint actually functions when it is in use. And we'll see some of the reasons why here, but just to name a few, here we can clearly see that if this knee weren't loaded, the distance between the femur and the tibia will likely be very different, right? Because you don't have that compression or that load bearing. So having the knee in a loaded sort of stance is one of the things which we really want when we're looking at knee OA diagnosis. And then one of the other things which we can also see here is that because of the two-dimensional nature of radiography, there's a lot of overlap, primarily over here and sort of in this region here. There's a lot of overlap, which sort of makes it difficult to actually see what's going on in the joint when we're using radiography. And so this sort of outlines why it would be beneficial to have a way that you can actually image the joint in both a natural sort of weight-bearing configuration, whilst also removing the issues that come with this 2D overlap that we get when we're using radiography. And so just to go briefly into sort of why we want weight-bearing imaging, I've mentioned this slightly before. And so the need for weight-bearing sort of rests on the fact that the functional behavior of the joint is affected by both loading and unloading effects. And so with weight-bearing imaging, we can obtain kinetic and kinematic information, such as the examples which we have listed here. And these are important because they actually allow us to correlate image findings with conclusions which we can make from clinical examination, as well as provide functional information, which is crucial for surgical planning and that sort of thing. And so one example which nicely illustrates the importance of weight-bearing imaging can be seen in the two ankle images which we have here, where you can clearly see that when you're in non-weight bearing, the distance between this bone and this bone seems fairly normal. But the moment you move to weight bearing, you see that there is that bone-on-bone contact. Similarly, on this one, we see that the distance between these two bones seems somewhat normal. However, when you actually load the joint, we see this sort of subluxation or this increase in the distance between them. So that's sort of just outlines the importance of weight bearing when we're doing these images. And so when we talk about weight-bearing radiography, as we saw earlier, we see that the main limitation is its two-dimensional nature, which results in sort of the superimposition of bony anatomy. However, traditional CT can overcome this by offering a three-dimensional visualization. However, it also comes with its own limitations, such as the inability to visualize the joint in a functional position. And so this is where sort of weight-bearing CT comes in, where it offers us the best of both worlds, where you can obtain both cross-sectional or 3D imaging, as well as having the individual standing in a natural position for that weight-bearing status. And so to bring this back to the context of knee-OA, which as I mentioned is sort of what I'll be focusing on, this slide nicely summarizes the benefits of using something like weight-bearing CT in knee-OA assessment. So just to briefly go over these, we can clearly see the advantage of 3D visualization when we look at these two images. So this is a radiograph and this is a cross-sectional coronal view of the same knee. And we can clearly see that with a three-dimensional visualization, we can clearly see this osteophyte, which is in the center here, as well as you can get a better idea of what the osteophyte here looks like. Whereas if you look at the radiographic image, it's a bit more difficult to appreciate the fact that there's actually some structural changes that are there. Furthermore, if we look at the effect of weight bearing, we've seen this before. When you have the individual in a non-weight bearing stance, we see that the distance between the femur and the tibia here looks normal. However, when you're actually in weight bearing, we see that for this exact same person, there actually is joint space narrowing or bone-on-bone contact in this case when they are in weight bearing. And one of the nice things which you can then do with a three-dimensional image is you can actually then generate some 3D joint space maps, which can actually clearly show you where sort of joint space narrowing or where problematic areas within the joint might lie. And so you can also see that when we have non-weight bearing, you might underestimate the total affected area which experiences joint space narrowing. Whereas if you're in a weight bearing stance, because of this sort of bone-to-bone contact or because of this extra loading, you can actually see that it's actually a lot more pervasive than you'd otherwise see with non-weight bearing imaging. Okay, and so current weight-bearing CT systems differ from traditional CT systems in the sense that traditional systems use a narrow fan beam, which gets translated axially along the anatomy of interest, as we see on the left here. Whereas weight-bearing CT systems use what we call a wide cone-shaped beam, which captures a large portion of the subject anatomy in a single rotation. So as we see here, we have a very narrow fan beam, which captures just an individual slice of the individual's legs, whereas with cone beam, we get this sort of a much larger volume image in one go. And so if we look at some of the advantages and disadvantages, we see again that with cone beam CT, we capture a much larger field of view in a single rotation. We also have the potential for lower acquisition time because we don't have to wait for the scan to go all the way around, capturing the entire anatomy that we're interested in. And we also have a more efficient use of X-rays. So in fan beam CT, the beam which is generated from the X-ray source actually gets collimated such that we only get this very narrow fan beam. And so there are a lot of X-rays which get sort of blocked from actually sort of going through the individual and hitting the target. So with cone beam CT, we actually make use of a lot more of those X-rays, which has implications on sort of system cooling and those sort of things, which typically make fan beam CT systems a lot larger, whereas cone beam CT systems can be a lot more compact because they don't need some of these requirements. However, what we then also see, which is very apparent, is with cone beam CT, you're going to need a much larger detector array because you're capturing a much larger volume, and so that comes with increased cost and sort of design of these panel detectors. Sorry. And then we also have potential for more image artifacts. So as you can see here, we're going to have more X-ray scatter primarily because your X-rays are traveling through a much larger volume. And so that means that they have the potential to interact with more matter, which will result in more X-ray scatter, which can deteriorate the quality of your image, right? And then one other thing which maybe isn't so apparent is that any movement during a cone beam CT scan will actually affect a larger region of your image because this entire volume is imaged in one go. Whereas in fan beam CT, you're only imaging a very small slice. So if you were to move whilst a fan beam CT was going on, that motion would likely only affect a very small region of your total imaged volume. So those are just some of the advantages and disadvantages there. So as we have seen, there are some advantages and disadvantages to using cone beam CT over fan beam CT. However, the question then becomes, how do these changes or how do these modifications actually affect some of the image quality which we actually get at the end of it? And so to get to answering this question here, we have two images of the same cadaveric tibial plateau taken with cone beam CT and clinical CT. And we can see that these two images are somewhat comparable to each other, and there isn't necessarily anything that sort of immediately jumps out at you. On the other hand, if we look at a knee scan, which I have shown here on the right, we can see some rather significant artifacts at the top and bottom, which are purely due to the cone beam geometry. So we can see them just about here. You see this artifact line here, and then some more, seems a lot brighter at the bottom, whereas we can see some blurring as we get towards the top here, right? And so this highlights the need for characterization to ensure that we know the full extent of our system's capabilities. And so that being said, cone beam CT is not necessarily new technology, and it has been around for about over 20 years, where it's mainly been used in dental applications. And so some of the most recent literature on characterizing cone beam CT systems have focused primarily on using cone beam CT to visualize soft tissue or to discriminate between different soft tissues. Some of the other ones have also mainly focused on characterizing systems which have a very small cone angle. So in other words, the field of view which they actually reconstruct is actually just very small. Other things are all their measurements have been sort of in plane. So when they actually don't characterize the full height of this cone beam, most of it is just in the imaging plane where the source is. Other things which I guess I've also come across is the fact that because we have this cone beam geometry, we get that excessive X-ray scatter, which I mentioned earlier on. We also get some technology-specific artifacts, such as the cone beam one, which we saw at the bottom in that knee scan earlier on. And there's also really no consensus on reliability of using cone beam CT to make sort of quantitative measures on structures such as bone, for example. And so what we wanted to see here was how pervasive are some of these artifacts, as well as also just sort of characterizing the system in terms of measuring some of the more standard metrics that we typically measure on CT systems. And so this then leads us to what was the objective of this sort of initial performance study, where we wanted just to determine the performance characteristics of a novel weight-bearing cone beam CT scanner in bone imaging applications. And so our study made use of a weight-bearing cone beam CT scanner, which looks like that over here. We also had a CT phantom, which was designed for cone beam characterization, which is the one we have on the right. And then as well as a bone mineral density phantom, which consisted of 3 rods of uniform bone mineral density ranging from 100 to 800 milligrams of hydroxyapatite per cubic centimeter. And I've also just added some of the dimensions here. And so as we saw earlier in an earlier slide, the first thing which was fairly obvious was when we started scanning, there was the presence of these artifacts in the reconstructed images. And so we wanted to get a better idea of where within the field of view can we actually make reliable intensity-based measurements. And so what we actually did was we took a scan with nothing in the field of view, and we're able to get a good visualization of what this artifact looks like. And so here we have what you would see towards the bottom of the image, and then here's what you would see towards the top of the image. And then using that, we were actually able to sort of actually decipher how of this total height of your total reconstructed view, how much of it is actually unaffected by these artifacts. And what we found was that even though the manufacturer in this case specifies that the total height of our field of view is just about 19 centimeters, the actual height which is unaffected by some of these pervasive artifacts is actually just about 12. So that will come in later on when we talk about patient positioning and that sort of thing, but this was sort of like the first step in sort of trying to characterize how we'd want to use this system. The next thing which we measured was the spatial resolution. Okay, and in this case, we defined the spatial resolution as the spatial frequency at which the modulation transfer function dropped to 10%. And so what we found was that the measured spatial resolution was actually fairly similar to the manufacturer specified resolution, meaning that we can actually expect to resolve features that are approximately, but it's about 300 microns thick. And so to put this back into a bone context, right, 300 microns is about 3 times the thickness of a single human trabeculae. And so when we look at these 2 images here, one from high resolution peripheral quantitative CT and cone beam CT, we can actually see that, okay, with this resolution, we can't necessarily get to sort of measuring bone microarchitecture as we would be able to in HRPQCT. And so next what we wanted to measure was the system linearity. And so what this is this gives us a measure of how the system responds to materials of different density. So this is an important measure because state-of-the-art cone beam CT systems are not actually calibrated to bone mineral density. And so the grayscale values which we actually get in the obtained images are not equal to sort of Hounsfield units or anything like that. So any calibration efforts would require a linear response. And so to measure this, what we did was we used serial dilutions of iodine solution, starting at 15 milligrams per milliliter of iodine. And as we see in the plot, the normalized signal intensity varied linearly with our iodine concentration, which in this case is good and is what we'd both expect as well as desire, because we want our system to respond linearly to materials of different density. So then one of the other things which we noticed in our knee scans was beam hardening, which occurred towards the center of the field of view. And so the implications of this were that sort of any intensity-based segmentation would either leave out large sections of bone or capture some of the surrounding tissue. So as we can see here, if we're trying to segment out the bone in this case, we're not necessarily capturing all of the bone at a threshold level of 700 attenuation units. Whereas if we go to 400, if we try to capture more of that bone, we end up picking up some other erroneous anatomy or noise sort of outside the margins of the bone. And even if we look at this beam hardening artifact over here, we clearly see that the grayscale value within the soft tissue here is very different to what we have elsewhere. And so this sort of shows that there's this beam hardening which is going on towards the center of the field of view. So in order to characterize beam hardening, what we did was we used those bone mineral density phantoms, and we plotted line profiles along their length. And what we did was we determined the average deviation from the true bone mineral density value. And so for the in-plane, or rather the axial orientation, we found that the deviation was actually far worse for the more dense rod, so the 800 milligrams of hydroxyapatite per cubic centimeter rod, and it was relatively stable for the 400. So it was still a bit noisy, but it didn't sort of show this significant beam hardening dip that we see with the 800. And so, as I mentioned earlier, a lot of the characterization work which had been done before focused on these axial sort of in-plane measurements. And so what we did is we want to extend that to also characterize the height of the cone beam. And so what we did was we then oriented our phantom standing upright, and then we did line profiles going down the length. And what we can see here is, the first of all we notice is the deviation is a little lower compared to what we saw in the axial image in the axial analysis. However, we do also see this very clear trend that as you move from the top of the field of view on this side to the bottom, the values which you actually get tend to sort of decrease. And this is consistent along all three rods. So this would suggest that this behavior was not based on the density of the rods which we were looking at, and it was more so a characteristic of either the reconstruction kernel which was used, or something else which is causing this sort of gradual decrease as we moved towards the bottom of the field of view. And so just to summarize at least some of the characterization work, we clearly see that the presence of the cone beam artifact has implications on patient positioning. And so in this case, care has to be taken to ensure that the anatomy which you're actually interested in is positioned away from these artifacts. And so also when it comes to uniformity, one key thing to note is that it's very unlikely that you would ever encounter a region that is sort of 18 centimeters long, which has a bone mineral density of 800 milligrams. That's sort of pushing the system to its sort of extremes. So you're not likely to really ever encounter this. However, this still raises the question on what are some acceptable tolerances which we can say, okay, we can work with these when it comes to cone beam CT uniformity in bone imaging. And then so when it then comes to some of the limitations and some of the future work, so obviously these results are very specific to the scanner which we were characterizing in this case. And what we've actually started working on now is we've actually started working on doing a comparison between cone beam CT, clinical CT, and HRPT CT, mainly looking at, again, trying to answer this question on acceptable tolerances. That's sort of where we're headed towards. And then something else which we're sort of looking towards doing is perhaps implementing some corrections which can account for some of the downward trends which we saw in the coronal plane, where we saw the trend clearly decreasing as you went from the top of the field of view towards the bottom. Okay. And so now to just sort of come back to, I guess, my project and where this sort of all fits in. So I was really interested in sort of seeing, well, with weight-bearing CT, we know that we can look at joint space narrowing and joint space width, but what about other knee OA features? So We know that cartilage degeneration is a common observation in knee OA. We know that sclerosis also occurs at the subchondral bone plate. And we also know that there are some bone mineral density alterations which actually occur at the joint, and these are related to things such as pain. They're also a predictor for future joint space narrowing. And then both sort of sclerosis and bone mineral density alterations have an implication on the mechanical behavior of the joint, or the bone in this case as well. And so that's sort of where those are some of the sort of the questions which came to mind when we were thinking about using weight-bearing CT in knee OA. And so in terms of joint space narrowing, we know that joint space narrowing is typically reflective of degenerative changes which occur in the cartilage, in the meniscus, or both. And so we're really interested in sort of answering the question, how does 3D joint space width measurements, so those 3D joint space width maps, which we saw earlier on, how do they actually compare with sort of cartilage thickness maps? Sort of tease out if the changes in joint space width are actually due to changes in the cartilage, or are they due to changes in the meniscus, or what's really going on? What do these joint space width maps actually tell us about what's going on in the joint? And then some other questions which we had was how accurately can we actually measure subchondral bone plate thickness using cone beam CT? And then lastly, as we mentioned again, bone mineral density alterations are sort of important in knee OA because they are related to pain, and they actually predict future progression of OA. And so we want to find out how reliably can we actually measure volumetric bone mineral density using cone beam CT. And so some of the project aims which we'll be looking at doing are sort of to determine the agreement between joint space width and cartilage thickness maps in both the patellofemoral and tibiofemoral compartments in vivo, as well as doing a comparison of the spatial variation in bone mineral density. This will consist of both an ex vivo portion and an in vivo portion, where we'll be comparing the spatial variation in bone mineral density in ex vivo samples using clinical CT, HRPQ CT, and weight-bearing CT, just so we can actually get a good idea of can this actually be done before we actually sort of move into sort of using it in vivo. And then the last thing was also just a comparison of subchondral bone plate thickness measures. Again, same sort of structure, where we have the ex vivo to sort of actually tell us how well can we do this using weight-bearing CT, and then applying that in vivo as well. So then, of course, because we have some ex vivos, we have a study design does consist of having some cadaveric human tibiae, which we've already imaged. And then in terms of our cohorts, we're actually looking to use two cohorts. So the first one is the Alberta Youth Prevention of Early OA PRIO cohort, which consists of individuals who have sustained an intra-articular knee injury, something about 10 to 18 years prior to when they would come in for imaging. And we're hoping to get about 50 individuals, fingers crossed. And then these individuals, we roughly about 25 to 36. And the whole idea of this cohort is we're hoping to capture early stage OA and sort of then compare, well, with early, if there are changes which we can see with weight-bearing CT in early stage OA, how do those compare with what we can measure in late stage OA, which brings us to the final cohort, where this actually consists of individuals who are about 45 to 70 and sort of awaiting for total knee replacement surgery. And so again, the idea is compare what we would see in early stage OA when we're looking at those cartilage thickness maps and those joint space width maps, and then looking at how does that differ in late stage OA, where we'd expect to see a lot more degeneration going on there. So what we'll be looking to use here is obviously we'll be looking to use weight-bearing CT, which will be used to acquire the bilateral knee images. And then we'll also be using extremity MRI, which will be used to sort of visualize the cartilage in the joint. And so today what we've also done is we actually developed an automated algorithm, which does these 3D joint space with maps, as well as measuring the subchondral bone plate thickness. And so again, what we want to be looking at is we want to determine the area with a certain joint space width that is below some given threshold, right? So by doing by following through this pipeline, we actually get these maps, and then we want to threshold this map to sort of see, okay, which areas of the joint are actually showing reduced joint space width. And then a similar thing when we're looking at the subchondral bone plate thickness. And then we want to compare that to our sort of cartilage thickness map and sort of see how do they sort of overlap, how do they agree with each other when we're looking at what we see in the joint space width map and what we see in the cartilage thickness map. And just to probably give a better explanation of that, so if this is our joint space width map, the one in the colorful one rather, right? What we're hoping to see is the areas of reduced cartilage thickness will sort of overlap and coincide with the areas which have reduced joint space width. That way we can sort of say, okay, well, the changes which we're seeing in joint space width might be due to changes in the cartilage thickness. And if not, then maybe the meniscus is playing a role or something else is happening within the joint. And then, so some of our primary outcomes would be just the spatial overlap of these areas. So spatial overlap of the area of reduced cartilage thickness and the area which has reduced joint space width. And then some of the secondary outcomes would be sort of, to measure the subchondral bone plate thickness as well as the volumetric bone mineral density in these individuals. And then, of course, we'll be using some Pearson or Spearman correlations to identify the relationship between these. So again, we want to see if decreases in cartilage thickness correspond to decreases in joint space width, and so vice versa, if increases in cartilage thicknesses correspond to increases in joint space width, that sort of thing. And then, of course, for the secondary outcomes, we'll also just be looking at bland Altman analysis to sort of compare what we're seeing in the different imaging modalities. So between weight-bearing CT, clinical CT, and HRPQ-CT, how different are these measures of bone mineral density and subchondral bone plate thickness when we use these different modalities. And so in conclusion, just from the characterization portion, just to repeat it again, we see that careful patient positioning is necessary to sufficiently visualize the bone. And it's important because you really want to avoid this area which has sort of these artifacts, at least that we saw at the top and bottom of the field of view. And we'll see that there's also potential to make intensity-based measurements on bone using cone beam CT. However, this also depends on where you are in the field of view, and there will likely be some corrections which will need to be implemented in order to account for some of the intensity variations which we see. And then just to wrap it all up, some of the significance as a whole for this project would be the results can actually be used to sort of establish the utility of using weight-bearing CT in assessing multiple NEOA related outcomes in a single scan. So with that, I'd like to thank all the members of Mansky Lab, some individuals here as well. And then I was asked to put a plug for some ongoing recruitment. So we are currently recruiting females aged between 40 and 75 who have healthy knees and no knee-related pain for a NEOA pain study, which seeks to characterize chronic pain in NEOA, as well as females who are aged 50 plus and females aged 20 to 40, both with healthy hands, for a dynamic CT hand OA study, which we are also doing at the Mansky Lab. And yeah, I'll be happy to take any questions.
So the floor is now open for questions. If anyone wants to get started. All right, I'll start that. So the one thing with this beam hardening, the axial one, can you characterize, like, is this a consistent effect that it's like the same kind of like slopes across the
the axial direction, you always get the same errors, or is it that changes each time?
So, okay, so in the axial direction, no, so we actually haven't looked specifically at what those slopes are. All we've seen is that there is a decrease as you move down. So that would be sort of, if we are to do any sort of linear corrections or trying to correct for that, we would have to sort of see if those slopes are the same or if they vary as you move throughout the field of view. And so yeah, that is definitely something which we're looking at doing.
Grant?
I'm curious, and I'm sorry if I missed it, this is what would you consider normal for the joint spaces? Like what's the healthy new joint spaces?
Right, so that's a good question. So obviously with joint space narrowing or joint space width, it can vary between individuals just because you might have different cartilage thicknesses and you might have your meniscus might be a different height between people. So healthy, and usually when they talk about NEOA diagnosis, it's usually based off sort of a baseline image and then a follow-up image. And between those images, they have to see a definite sort of joint space narrowing, so definite progression in joint space narrowing. So there isn't really sort of what's considered normal. It's sort of relative to that individual and relative to the different time points.
Question?
Sure. It's just a very naive question, but does the system have a beam hardening filter or no?
Yes, so it does have a beam hardening correction filter, and I might be able to show it here if it allows me. Here. So yeah, it does have that, and we can actually, so here we see that at the 800 milligrams of hydroxyapatite, that filter doesn't really, do much in terms of correcting this beam hardening here. At 400, it does a decent job, but at sort of 100, it almost overcompensates for it. So it actually does, it does have it, but its performance sort of varies depending on the density of the material that you're looking at.
I was just curious whether this problem could be broken into two separate things, because it seems like there's the joint space issue, and then there's the, I don't know, bone structure issue. And so I'm wondering, for joint spaces, you don't need to do that at the same time. So couldn't you do a weight-bearing conventional X-ray and do several different views, and then separately from that, do a CT or HRP QCT to get the microstructure of the bone. And then presumably when they're weight bearing, it's not changing anything within the microstructure, it's just changing the joint spaces. And so couldn't a conventional or series conventional X-rays provide the information for the joint spaces? And then you can use your best CT method to get the microstructure.
So yes, so you could do that. However, one of the things which at least they've found with radiographic measures is that they're actually less sensitive to changes in joint space narrowing compared to weight-bearing CT. And so that's why there is that sort of push towards using weight-bearing CT, because it has been found to be more sensitive in detecting changes in that joint space width. So I guess to answer your question, it can be done, but we're sort of trying to keep everything within the scope of weight-bearing CT, just because it has been found recently to be more sensitive than sort of radiographic.
When you're talking about subchondral bone plate thickness, I was like, oh, I wonder what the thickness of subchondral bone is. So I Googled it, and it was a Steve Boyd paper that used the HRP QCT. And it was like 0.5 something to 0.7 millimeters.
Yeah.
But with the clinical CT over in McKay, the slice thickness is limited to like 0.625 or 0.65 or something like that.
Yes.
So how are you going to get subchondral bone plate thickness from the clinical CT or even the weight-bearing CT?
Right. No, that's a perfect question. So I think for the weight-bearing CT, the spatial resolution is about 0.3 millimeters.
Okay.
So we wouldn't necessarily be able to sort of really get down to the nitty-gritties if we were just to use it as it is. However, there actually has been some work done out of the University of Cambridge, I believe, where they actually used a signal processing approach to sort of actually make these measurements. And these measurements, using this approach, you can actually measure features which are smaller than the actual resolution of your scanner. So I don't have it on my slides here, but I did implement that when I was sort of setting this up here. So essentially how it works is you sample the image sort of in the region of interest, and then you get a contour of the bone, and using that contour of the bone, you assess the not using the contour of the bone, using those signals which you get when you probe the image, you can actually do some interpolation within the grayscale values to sort of find out where exactly is the limit of the or the margin of the bone in this case. So you can actually use sort of that approach to get sort of sub-millimeter even measurements which are not dependent on sort of the point spread function of your system.
Okay, yeah, I think I've seen some of that work where people are trying to like resolve the thickness of a thin cortical shell, like a jaw or something like that, and they use clinical sensitivity.
Right.
Okay, that's cool. What about, you want to assess volumetric bone mineral density. So what do you think like early stage OA would look like in terms of that marker? Or even late stage OA, like what would, let me ask a question, a better question. I'm assuming that when somebody has osteoarthritis, they have sort of a very low volumetric bone mineral density below the subchondral plate in the trajectory. But then maybe they have hypermineralization and sclerosis in the subchondral.
Yep.
So do you think with your level of resolution, you'll be able to segment out those individual compartments and be able to do volumetric bone mineral density measurements within those individual compartments?
So in terms of the individual compartments, what we're trying to look at here with volumetric bone mineral density is really more interested in sort of the spatial variation, because we fairly sort of certain that, not certain, we have a fair idea that we probably won't be able to get to measures which are identical to what you would get in clinical CT or HRPQ CT. So because of those scattering artifacts and that sort of thing. So what we're trying to see is, can we actually just decipher between regions of different bone mineral density using weight-bearing CT? Not necessarily that are they true values, but can we actually see differences which show up, which we can also see with clinical CT as well. So the values might not be the same, but if the sort of the distribution of bone mineral density is somewhat similar, then we can solve.
And you're talking about differences, you mean sort of longitudinally, or do you mean like between people with OA and people without OA?
So both between people with OA and without OA, as well as just within the same individual as well. So as I mentioned earlier on, there's going to be this ex vivo component and an in vivo component. And so what we want to see in terms of bone mineral density is if we were to scan individual A with clinical CT, and we sort of generated a bone mineral density color map of their anatomy, how does that color map sort of compare to a bone mineral density color map which we obtained using weight-bearing CT? So it's just sort of a first step in sort of trying to see if we can actually do bone mineral density measurements with weight-bearing CT, not necessarily are they identical. Yeah.
Okay.
Well, we got two questions from audience, online audience. The first question is, does the knee joint space depend on the knee joint angle?
Yes, so it does depend on the flexion, so the extent, the degree of knee flexion which we have. And so just trying to remember, there are a few studies who have done which have looked at the impact of having different angles of different extents of knee flexion in measuring joint space width. And I think they found that when you image the individual with a flexion angle around about 20 to 30 degrees, that actually provides a more sensitive and more representative measure of joint space width, as opposed to if you're standing in full extension or anything more than sort of 30 degrees of flexion. So yes, it definitely does depend on the amount of flexion that you have.
So the second question is, does the knee joint space depend on time of loading? In other words, does it matter if I load my joints for 10 seconds or 10 times?
So what was that last part? For 10 seconds or?
10 times. I don't know. No, 10 minutes, sorry.
Oh, 10 minutes?
Yeah.
Right. Yes, so it would, so that sort of comes to answering the question of the tissues which are actually found within the knee. So if you're thinking about cartilage or the meniscus, so particularly in cartilage, cartilage compression properties may vary. And so if you have been sort of just standing for 10 minutes, and then you get imaged. So obviously what you're going to be imaging is that cartilage would be in a compressed state, right? Whereas if you are not weight bearing, that cartilage is not in a compressed state. And so that is one of the limitations which my study design currently has, is because with MRI, we're not imaging in the weight bearing position. So that cartilage is going to be unloaded. However, there is some work out there which actually says that after sort of exercise or after sort of any activity, the cartilage actually takes anything up to 90 minutes to actually recover to its pre-compressed or unloaded state. So it does actually have effect, but as you said, it wouldn't, at least in the context of this study, it shouldn't be a major concern. No.
Thank you for your presentation. Just some logistics, because I'm not familiar with weight bearing CT. You mentioned it was low radiation but sensitive to motion. So how low is low radiation? How long do scans take to acquire, and then what kind of motion is too much?
Okay, so radiation, I think we were doing some of the calculations just last week, and I think the radiation for just a single knee, for a unilateral knee scan, is just about 38 microsieverts. So it is lower, I would say, than clinical CT, almost most definitely. However, it is maybe slightly higher or maybe similar to what you get with HRPGCT, if I'm not mistaken. And so I missed the second part of your question.
Oh, yeah, how long is scan?
Oh, so the scan takes about 40 seconds.
Oh. Okay.
Yeah, 40 seconds to scan the entire bilateral stance.
And then so in terms of motion, is it just like a little, like how common is motion, or is it, I guess 40 seconds is pretty easy to stay still for.
Right. So I'll be quite honest, I'm not entirely sure. I haven't seen many images or even just studies which have looked at the effect of motion in cone beam CT systems, apart from just the sort of the theoretical that because you are imaging a larger volume at one particular time, any sort of motion will affect the majority of the image. So in terms of how much motion, unfortunately, I'm not entirely sure at the moment. Yeah.
Another one. What's the range of motion capacity of the scanner? Like what kind of positions? Person standing, but how much flexion you can go to?
And I wish I'd put in more images. So you can definitely, so the size of the gantry is large enough to fit, most if not all people, right? And so you can definitely stand in full extension, and there's definitely a lot more space to stand in. I'd say maybe up to, I don't know, maybe 60 degrees of flexion, perhaps, because yeah, there is a lot of space behind the individual. And so again, I wish I had more images to show, but it is pretty big. It is pretty big, yeah.
How do you choose like the posture versus stance? And like, if I want to stand with, there's many different step widths that I take, and presumably that will affect the joint space.
Yep.
measurements.
Yep. So we do actually have some a positioning protocol, which we have borrowed from some other groups who've done this before. And so what we sort of try to ensure is that it's standard across everyone. So we do have a positioning plate for the feet, which makes sure that your feet are sort of, you have your feet in about 10 degrees of external rotation. And then there's a positioning sort of platform in front of you, where we essentially what we want is you want to have the person standing in what they call the Leon Schuss view position, where you have your patella and your thighs right up against the platform. And so that should sort of give a standard sort of 20 to 30 degree flexion position. Yeah.
Just not being very familiar with OA, what sort of markers of early OA are you expecting to see in various different That's a very broad question.
Yes. So, so I guess specifically in the early OA group, with them, we're really more interested in looking at the subchondral bone plate thickness, because that there have been studies which suggest that changes in bone actually occur before we see changes in cartilage. In the sort of late stage group, we're hoping to see those changes in both cartilage and the bone as well. We're not really looking into other markers, such as structural markers, such as osteophytes and that sort of thing, mainly because that's been done, and they have shown that weight-bearing CT is better than sort of radiography to sort of identify these. So we're just more so interested in trying to determine the time course of these OA changes, mainly in bone and cartilage, using weight-bearing CT as the modality. Yeah.
One very small question. You mentioned in passing that cone beam CTs aren't calibrated for bone density. What are they calibrated for?
So they actually just provide the units which we get. They call them just attenuation units. So it's just a sort of an attenuation coefficient of the material which you're scanning. That's sort of the units which we actually get from the scanner. It's not Hounsfield units, it's not sort of Bowman or density or anything like this. Because of that excessive scatter, you can't necessarily then say this is Hounsfield units if there might have been some effect due to scattering in that case. So they just refer as a blanket term, just attenuation units in general.
More questions? Cool. All right. Well, if not, let's thank our speaker again.